So I'm just going to share my screen now to start. So as Arlene said, I am a GP in Oxfordshire, and I was clinical champion for the Spotlight project, which ran for a year. And in that time, we developed an educational program, GP workshops, and also the Lyme disease toolkit that we'll come to. And the key thing that I'm keen to get over today is the basics, what it is that is happening in primary care and what we need to do. Because really, although everyone thinks of Lyme disease as being quite complicated, it really is a primary care illness, and we hold the key to early diagnosis and early treatment. So my feeling is that our role in primary care is to raise patient awareness, and that means help them avoid tick bites and know when to present to us. And of course, they're not coming into the surgery at the moment because of COVID. So another option is to make sure you've got something on your practice website, just letting people know what to look out for, when to present, because they're so concerned at the moment, either not getting appointments or not bothering the doctor or the nurse, that they're not going to be coming in. And on that same point, they're probably not coming into the GP, they're coming into the nurse, or they're going to see the pharmacist. And in fact, I had four cases in July, and one of those was specifically referred by a pharmacist. Early diagnosis is key. So unless they're presenting early, even if they don't feel particularly unwell, if they recognize that they might have Lyme disease because of the rash, they'll turn up early. But then they risk not being diagnosed by whichever clinician sees them. So we've got to raise awareness in that area. In terms of treatment, the NICE guideline is what we should be following in the UK. And we'll come to that later. And accurate recoding is really important, because these days, if we're diagnosing more clinically, as NICE advises, there's going to be less evidence available. And within that, you need to be aware that, as well as, because it's so difficult to diagnose, as well as coding Lyme disease or EM rash, you can code suspected Lyme disease or suspected EM rash. And that's fine to do that. And it is important, because a lot of the time you can't be 100%. So recognizing late Lyme disease, this is the case where you may have patients who used to be really well, and now suddenly they've got multiple problems, seeing multiple consultants, and we may be the only people as specialist generalists who are picking up that there's an awful lot more going on than each consultant is aware of. And then patient support, 5 to 20% of patients don't recover, and this is based on peer-reviewed evidence from the USA and Europe. So we'll come to that later. Why is my... Okay, so this is the toolkit that we've developed, and the idea is that this should be a single point of access for everything you might need to know. You can easily Google it. It's open access to everybody. It's freely available to patients and clinicians. And we aren't able to keep updating it, but it has got most of the links to the information that you need. We're about to do a short update very soon. There's also an e-learning module with the RCGP, but unfortunately that's no longer freely available to everybody. It is only freely available to RCGP members. Other people have to pay. So I just want to give you a bit of a background. What I will say before, what I should have said at the beginning is, please don't feel that you need to write any notes. I'm quite happy for all my slides to be shared. And the whole talk is being recorded. So Lyme disease is caused by a bacteria, a spirochete called Borrelia burgdorferi, and it's spread usually by the bite of an infected tick, and is the most common tick-borne disease in Europe and North America. So it's actually been apparent to many clinicians within Europe over about the past 100 years. The connection with tick bites and rashes and paralysis and neurological symptoms was noted. But it wasn't until the 70s when it became more of an issue in the States that the correlation with tick bites and bacteria was noted. So the name Lyme disease, so it's not Lyme's, it's actually Lyme disease, and it comes from the town of Old Lyme in Connecticut, where a group of children, a large number of children, were being diagnosed with juvenile rheumatoid arthritis. And it was actually the parents who brought this to the attention of the authorities, because there were so many children, and it was subsequently found to be due to a tick-borne infection, which was subsequently shown to be Borrelia. And in 1988, Dr. Andrew Pashner, who's a neurologist in the States, described it as the new great imitator. And for those of you who aren't aware, one of the names for syphilis was the great imitator. And syphilis was a spirochete like Borrelia, which had primary, secondary, and tertiary stages. So it has multiple genus species. Only a couple of them are probably relevant within the Europe or the USA. But the different genus species probably cause different types of symptoms. In the USA, it tends to be more arthritic symptoms. In Europe, it tends to be more neurological. The testing is a bit complicated. It's a two-tier system where you send blood to the local lab. If it's positive, if that result is positive or indeterminate, they will send that off to the local Lyme unit, either at Public Health England at Porton Down or up in Raigmore Hospital in Scotland. So you can get false positive results, which is the reason they do the second test. But there is also the risk of false negatives due sometimes to the test being done so early or having had early antibiotics. And the key point is that Lyme, a negative test does not exclude the diagnosis. But unfortunately, many clinicians don't seem to still acknowledge this fact, even though it is part of now the NICE guideline, and they're still being sent away. Incidence is increasing. Lab confirmed cases probably only reach about 1,700 a year. Formal estimates suggest 3,000 a year, but some more recent research suggests it's probably anywhere from 8,000 to 10,000 a year minimum. So it affects males and females. It can occur at any age. And we know that there's a higher incidence up in Scotland and in the southern counties of the UK. And we know that ticks are most active between March and September, but it's now become apparent that there is some activity all year round, but the most likely time to get bitten is any time from March to September. And so, as I mentioned, there's more research coming out all the time, just looking at the patterns of the type of patients people who are becoming infected and the incidence. And this is just looking at the population demographics, and you can see that it can affect people of any age, from a baby left lying on a picnic rug in a park to a middle-aged person out hill walking to somebody gardening, so any age really. And the Big Tick Project looked at the risk of tick infection, and that looked at Scotland, south of England, Norfolk as being high-risk tick areas. So we know that ticks are small arthropods that are blood-sucking, and there are several species native to the UK. And this is a picture of the life cycle. So there are 3 stages at which they would take blood meals. First, the larvae after they've hatched, at which point the larvae aren't infected, but they will then feed off small mammals and birds, and then develop into nymph ticks. So the nymph ticks will be tiny, maybe the size of a poppy seed, but they could well be infected. And these are the ones that are easily missed. The nymphs will then feed either on, again, small mammals, birds, deer, but also potentially on domestic animals and humans if they happen to be within their environment. And then finally, the nymph will feed again. After that feed, the nymph will molt and become an adult. The adult ticks will again attach to deer, small mammals, and humans, but they're probably much more visible. So this is kind of habitat, but it's not necessarily rural areas. You can still see ticks because of the fact they carry on birds and animals that you see them in your garden, in parks, so you're at risk in multiple areas. And although, because ticks are painless, their bites are painless, they inject anesthetic, they might go unnoticed. And although you think, well, you probably wouldn't miss a huge tick attached to your forearm, you will miss a small tick attached behind your knee or an area of the body that you can't see. But because you're bitten doesn't mean you'll get infected. The infection rate amongst ticks is anywhere from 0 to 16% in different areas of the country. And in the UK, they're normally, the infections are usually Borrelia guerini or Borrelia abszelii. The next question is this issue of time needed for transmission. And there is no proven minimum time. There are plenty of suggestions in the past that you needed to be attached for 24 hours, 48 hours, 72 hours. There is no proven minimum time. And if the spirochetes happen to be in the mouthpiece of the tick, then they will transmit more easily. Also, if the tick is removed traumatically, it may well regurgitate its contents into the person, even if it hasn't been attached for that long. The other issue is knowing how long a tick's actually been attached. The fact you've removed one doesn't mean there isn't another one you haven't noticed. Another thing to be aware of is that ticks can carry multiple infections. So patients may present slightly unusual symptoms, or they may not respond to the treatment for Borrelia because they've actually got more than one infection going on. And ticks don't fly or jump. They just wait on vegetation for an animal or a human to pass by, and then they sort of attach themselves, climb on, and then they do something called questing, which is where they move around either on clothing or on the skin till they find a nice warm place to attach. And as I said, because they're injecting anesthetic, no one notices. And you can see that tiny mark on the wrist there, which is a nymph tick, and why they're easily to miss. Whereas that huge engorged tick would be much more difficult to miss. If they do attach and they're not noticed, they will stay for several days and then they'll probably just fall off again. But the longer attachment, the greater the risk of infection. So one of our questions actually was whether children are bitten above the waist. And in fact, they are usually bitten above the waist. So that's what you need to be looking for, what parents need to be checking for. Ticks, they might be under the arms, it might be behind the ear, they might be in the neck, they might be in the hairline. Whereas adults are probably more likely to be bitten on arms and legs. And prevention is really better than cure. And it is really, the suggestion is shoes, long trousers, which we don't necessarily all feel like wearing on a lovely summer's day. Light clothing, so you'll see the ticks, brushing the clothing off, showering afterwards to make sure you've checked for ticks. The other thing is to use maybe insect repellent on skin or on clothing beforehand to try and avoid the risk of being bitten. And walk in the middle of tracks, not through the long grass, and just be tick aware, really. When you get home, be aware of checking children and pets, because pets can carry ticks into the house, which may then subsequently bite you, even if they didn't bite the animal at that time. And tick removal is important. It's a key issue. Once you've been infected, you need to remove it, or bitten, you need to remove the tick as soon as possible, but as carefully as possible. In the past, there were issues, suggestions such as smothering it in oil and waiting for them to fall off, covering them in nail varnish. I think lots of army people are quite happy, quite like the idea of setting fire to them with cigarettes. But the key is to get them off carefully, ideally using a tick remover or a tick card. And this next slide was just going to show you how to use a tick remover. So the idea is that you twist, not because the tick has a corkscrew head, but because it's easier to remove because it's got a brush effect mouthpiece. It doesn't matter whether you go clockwise, anti-clockwise, it's just to do it slowly and carefully. If you're using narrow tooth forceps, then get as close to the mouthpiece as possible, as close to the skin, and then just pull firmly. You don't twist with forceps. But they really are quite unpleasant. Many of you may have had experience taking them off your animals. So just looking at Lyme disease, the stages of Lyme disease. And these are described as early localized, early disseminated, late disseminated, and then the persistent symptoms, which are given a couple of different names, such as chronic Lyme, post-treatment Lyme disease syndrome, or post-treatment Lyme disease. And what I want to look at is how those patients are going to present in primary care. So they might come in asking you to remove a tick, though, as we said, it's probably less likely at the moment with COVID. They might come in sure they've got an EM rash. They might come in with an insect bite. And I would sort of highlight that every time you see a patient, we see a lot in the out of hours where the key information is insect bite. Try to have in the back of your mind, is there any reason this could be a tick bite? Patients will be able, if you go into more detail, as I'll explain in a minute, you can try and get an idea of whether this could have been a tick as opposed to a normal fly bite, horsefly bite, this kind of thing. They might just come with an unusual rash. If they come in, some of the times people are coming in having had a tick bite, they've removed the tick, they feel perfectly well, but they're panicked. They want a blood test, they want some antibiotics, they've been reading all about it, and you need to be confident in reassuring them that there is certainly no point doing a blood test, it's unlikely to be positive within 4 weeks of a tick bite. And if they're completely asymptomatic, there's certainly no reason to do a test. And there are only a couple of reasons why you might have to treat prophylactically. Certainly in some areas of America where there's very high tick infection rates of maybe 50%, they probably do treat prophylactically a lot more. They might come in with a history of tick bite, tick exposure, and now they've got a rash or they feel unwell, and that will probably be a lot more straightforward. But they might just come in the middle, even now, with vague flu-like symptoms. They feel exhausted all the time, they've got no energy, they've got aches and pains, they just don't feel right, and you need to go back to, well, when did this start? Is that, is there anything they've forgotten to tell you? Did they have a funny rash? Did they have a tick bite? And there might be the people who've become chronically ill, which is again where we mentioned earlier, just having that on your radar is to think about whether they've been tested. Also, the ME and chronic fatigue patients, have they ever been tested for Lyme disease? Previous history of Lyme disease, some patients will get recurrent symptoms, and other patients might come with blood tests from outside the UK and asking you to treat, and that's a very complex area that will be discussed at a later meeting. So if they come in with a tick bite, as I said, just try and know when they were bitten, where it was that they were bitten, where's the site of the bite, how long do they think it was attached, how easy was it removed, have they had any symptoms so far? If not, then give them advice on what to expect and to come back if they're unwell, and make sure everybody in the practice is on the same wavelength. There's no point one doctor or nurse telling them to come back, and when they come back they get told, well, you haven't been to the New Forest, so you can't possibly have Lyme, or there's no Lyme in the UK, which is still what happens in a lot of places. It may or may not be appropriate to test, but probably not within 3 or 4 weeks of a bite is probably the earliest you might get a positive test, unless they're already quite unwell. Think about whether there's any indication to treat prophylactically. Maybe if they'd had multiple bites all at the same time, maybe if they had other ongoing illnesses, it might be appropriate. And if there's any clinical suspicion of Lyme disease, based on NICE guidelines, you can treat. So symptoms at the early stages may just be the rash. They may feel completely well, but the rash is diagnostic and you treat it, but it's only present in 70% of cases. They might have flu-like symptoms, aches and pains, neck aches often common, migrating muscle pain, joint pain. And the erythema migrans rash is not as easy as you might think. It's not necessarily a bullseye. It could just look identical to cellulitis or an allergic reaction. It probably occurs 3 to 30 days after the bite, and it's usually painless, but sometimes it could be a bit hot or a bit itchy. And don't be misled by the patient. You want a clear history. They may assume they just had an ordinary insect bite, but you need to go into detail. And if the rash has gone away, but they've got a clear picture maybe of what it was and that they know the story, that doesn't mean the infection's gone. You still need to treat even if the rash is gone. And remembering, as I said before, they may go to the nurse or the pharmacist. So that's a typical rash. It would be difficult to miss that one, but it's not always at the site of the bite. And there are a couple of others that can be quite unusual. They may even be multiple once the infection is disseminated. And the bacteria can disseminate around the body quite quickly. So as I said, when someone presents with an insect bite, get some detail. Is there any chance this can you honestly say this is an allergy or cellulitis? Does it need to be a diagnosis of exclusion? And maybe you need to discuss, have a shared decision-making process as to whether you start antibiotics. So these are the kind of symptoms you get into the disseminated stage, which can occur very quickly within weeks, but it may take longer. Facial palsy, every time you see a facial palsy, think about whether this could be Lyme disease. They may get palpitations, chest pains, breathlessness, and anxiety seems to be a part of the actual illness rather than just anxiety about being unwell. It seems to be a symptom. Severe unexplained pains, neuropathies, even meningitis. And patients may not give you all the history. It may need some detailed questioning to get the full history. In terms of treating facial palsy, you've got to think clearly about that one. If you can clearly know that it was Lyme, you can treat with antibiotics. If you don't know, then you're going to have to think about whether they need steroids as well, because it really wouldn't be acceptable to assume it might be Lyme and then it turn out not to be. So late or persistent symptoms could be really anything, all sorts of different symptoms can occur weeks, months, years. And sometimes they're so random and so varied that patients get diagnosed with functional disorders or psychiatric illnesses. Children might be particularly difficult because they just become a bit tired, fatigued, maybe they develop neurological symptoms, maybe their behavior changes, whether that's teenagers or young children. And sometimes it's when something else like a facial palsy develops that you suddenly get the diagnosis in young children. And it's been described as the new great imitator because it's been misdiagnosed as many of these other conditions or difficult to differentiate from these. Particularly, I'm aware of a consultant, a doctor in America who was diagnosed with motor neuron disease 15 years ago, subsequently found by 4 consultants, subsequently found to have Lyme disease and recovered. So if it's on your radar, you're much more likely to think about it. I'm sorry, I'm going to have to speak quite quickly now. So the NICE guideline, the positives are, it says the EM rash is diagnostic, you treat it. You don't need a blood test, you just treat, even if it has to be a suspected rash and you've discussed with the patient. You can treat based on clinical suspicion, even if you're waiting for a test to come back. The actual guideline, the timing of tests and things you can find from the toolkit. So what they suggest is you take a blood test. If it's negative, you should wait 4 weeks for the next blood test. But on the other hand, if your patient is ill, do you really want to wait 4 weeks? You could still do the test in 4 weeks, but you may need to get on and actually treat. Minimum 21 days of treatment and give a second course if they're still unwell, and a negative test, as we said, doesn't exclude the diagnosis. But there is limited evidence base for these guidelines and no recommendations on persistent symptoms. Testing you send to your local laboratory, it comes up under Borrelia, not Lyme disease. And you can speak to the Lyme labs if you're not quite sure about the information. The first test will come back in 24 hours. If they've sent it to the main lab, it will take possibly 2 weeks. And neuroborreliosis is much more difficult to treat sometimes, to diagnose sometimes, because an MRI doesn't exclude it and CSF findings can be variable. Treatment, I'm not expecting you to be able to read this. You can click onto it easily from the toolkit. And early treatment is the key. Children, the advice is discuss with a specialist if you've got more than just a simple erythema migrans rash, but don't delay treatment in the meantime. Adults, first line is doxycycline because it treats co-infections as well as Lyme, but at a higher dose, 100 milligrams twice a day. If it's amoxicillin, it's 1 gram 3 times a day. So it is a higher dose. Jerax-Herxheimer reaction is sometimes a reaction to the antibiotics, but it may come on within a couple of days, but it should settle, and it's normally just an exacerbation of symptoms. Plan to review at 3 weeks because they may need further antibiotics, and if they've got significant symptoms, they may need admission for IV antibiotics. Children need much higher doses, so you're talking about 30 milligrams per kilogram in a child of in children under the age of 9, or even over if they can't take doxycycline. But doxycycline is first line in age 9 to 12, which isn't it for most infections. It wouldn't be recommended first line, but it is in Lyme disease. But high doses based on the guideline. Specialist advice from the labs or the local consultants, but there are no specialist clinics. And my experience is that most secondary care consultants, Dr. Lambert excluded, have limited experience of Lyme disease, and they will readily admit this. So I don't think they can be considered any more expert than many GPs. Other guidelines include ILADs, which suggest much longer treatments and to retreat if symptoms recur. European guidelines are aware of the limitations of the guidelines that are available. Infectious Diseases Society of America have very restrictive guidelines, which have been an area of major dispute. And what about persistent symptoms? Patients are being told that chronic Lyme disease doesn't exist and it's all in the head, and they've just got the aches and pains of daily life and go away and we can't really help you. But actually there's a lot more evidence now than there was. And if for those of you who want to read more, there's a lot of research coming out of Johns Hopkins. Johns Hopkins University in the States is well respected, and they're doing some very, very good research. Columbia Lyme is another. Bay Area Foundation, Lyme Foundation is over in California. A lot of the limitations are based on 4 randomized controlled trials, which state that there is no evidence just to to support extended courses of treatment or retreatment. And this is a report where they, biostatistical analysis review, suggesting there is evidence and the need for more research. Now, why have I suddenly lost my, I've suddenly lost my files. What have I just, oh, I see what I've done, sorry. I have suddenly lost, because I clicked on a link accidentally, I have suddenly lost my, okay, good. Sorry about that. So, as Dr. Lambert mentioned, there's about 500,000 cases a year in the USA now, probably at least 10,000 in the UK. And we know anywhere, we've got, I've said 10 there, but it's actually 5 to 20% of cases, even when they're diagnosed at an early stage with an EM rash, will have persistent symptoms. And that's estimated to suggest 2 million cases a year at the US at the moment of post-treatment Lyme disease. And the research coming out of Johns Hopkins shows that although physical examination seems normal and lab testing seem normal, a bit like long COVID, these patients are very, very unwell. And there is evidence to support that. So Johns Hopkins have defined a group of patients with what they call post-treatment Lyme disease. And they've postulated that this is a combination, that maybe some people have persistent infection, maybe it's a genetic response, an immunological response, an immune response to the infection. But they've been keen to point out that it implies post-initial infection. Post-treatment Lyme disease means post-initial treatment. It does not necessarily mean post-infectious. And the risk factors for this will be delay in diagnosis, which is where we come in, the severity of the initial symptoms, which may be a result of delay in diagnosis. And if patients have neurological symptoms, they've got much less chance of recovering. So the other area to think about is, any patients have persistent symptoms but never been diagnosed with Lyme. Many patients might have been diagnosed with COVID at the beginning of the epidemic, of the pandemic, where there was no testing. Maybe they had very vague symptoms. They're assumed to now have long COVID, but maybe no one ever thought about testing for Lyme. And think about non-Lyme causes, because you wouldn't want to miss any of those. It's important not to get blinkered by the thought that this is all Lyme disease. So the key points are, it's complex, testing is unreliable, early inadequate treatment is where we come in, even if diagnosis has to be suspect rather than absolute. And there's no international consensus on treatment. The EM rash is diagnostic, and if you've got unusual symptoms, think about Lyme. If patients ask about Lyme, then take them seriously. And if they request a Lyme disease test, I can't think of many reasons to refuse one, really, and exclude other diagnoses. There is something I very quickly need to mention at the end. So, sorry, my last thought was to suggest, think about developing a Lyme-aware practice where everybody else is in the same, on the practice is in the same wavelength. Think about doing a practice audit, quality improvement activity, look at how many cases you've got, look at if that picks up once everybody's more aware. And in May, there is Lyme awareness, and there are leaflets and posters available. At the end, Arlene is going to put up a contact detail for Lucy Delaney at the University of Liverpool, who is looking for practices who might be interested in becoming involved in some research, basically when they diagnose a case, having the facility to take photos, to upload information and improve practice primary care outcomes. So that's the end of my presentation. I'm sorry that last bit was a bit rushed. And all of this will be remaining online, and I would recommend you to look at the toolkit and use that as a day-to-day aid with patients. Thank you very much.